what I'm planning to do is I'm planning to kind of go through this in two halves. The first half of the talk being an outline of the general issues around mental health in patients living and dying with cancer. And forgive me if I'm being too basic in a lot of areas. What I'd like to do is just to give you, I suppose, a number of nuggets of clinical practice. So I'll be skimming through a fair few things, but I'm hoping that people can put in their comments or questions, maybe any areas they'd like me to go into in any further depth. And the second half will then relate to the actual topic of the conference in terms of dynamic changes in oncology and the relevance to palliative care. So I'm a liaison psychiatrist in Beaumont Hospital. That's a psychiatrist who works with patients with a whole range of medical conditions. And I suppose there are a number of kind of basic pieces that I'd like to just refer to in terms of again, language. And you've emphasized, Michael, my interest in mind-body medicine and that whole area of the language we use. So first of all, in our current day living, stress in general tends to be a dirty word nowadays. It's a negative word. And I think what's really important is we go back to the basic premise that stress is normal. Stress is our healthy, adaptive response, predominantly through our fight or flight system in terms of response to change in our environment. So stress is really important and normalizing that. What we do have then is we have a continuum of stress and distress between normal adaptive adjustment to stress, including to illness, including to a diagnosis of cancer, including to a diagnosis of terminal cancer. And when it ranges into the moderate areas and severe areas of distress, such that it becomes maladaptive and disabling. And you'll be familiar with the Yerkes-Dodson curve, where we need that increased stress response to focus on our increased attention and interest in order to achieve optimal adaptation and responses. But we don't want to go over that curve in terms of impaired anxiety associated with strong, impaired performance associated with strong anxiety. The other thing to be aware of is that stress is a response to change. And so we're talking about positive change as well as negative change. So people tend to think that they only should have a stress response to a negative event, but any change, including good news about your cancer journey, etc., in itself will still trigger the same stress, sympathetic, parasympathetic, autonomic hyperarousal system in the body. So being aware of that and helping patients to understand that. And really, this is where it's all happening. So I suppose the challenge is we've fallen into this Cartesian split between mind and body, where physical disorders in the body are managed in acute hospital settings, and mental health disorders are managed in other settings. And in fact, all we're talking about is disorders affecting the brain when we talk about mental disorders, not just disorders that are static within the brain, but actually plastic responses of the brain in response to our external environment and in response to our internal environment. So that whole process of psychoneuroimmunology, so the external stressor. So for example, the man whose wife has died is more likely to die himself in the following year than a man of the same age and health whose wife hasn't died. So the external event triggering activation of the hypothalamic pituitary adrenal axis, a whole range of immune, hormonal, autonomic hyperarousal, neurological system responses, and that whole fascinating areas of inflammation, and how we're getting, I think, a better language around that in the context of COVID, that these are not external events. And you may be aware, for example, the group of patients at highest risk of mortality from COVID are patients with schizophrenia. And that's not just related to lifestyle management factors or metabolic syndrome, but also related to the relative hypoimmunity condition that's associated with schizophrenia. So this separation of the mind and the body, it's really important to understand that in fact these are fully integrated. I've been saying to medical students for about 10 years that I expect we'll routinely be using anti-inflammatories and immune modulators in the coming decades around what we currently call psychiatric disorders. So in the olden days, we used to think that people with epilepsy were possessed by demons. As our scientific knowledge improved, we became aware that wasn't the case. And so what we're working with here, and I'll maybe refer to it later, is not just structural changes in terms of hardware of the system, but also functional changes in terms of the software, largely mediated through the psychoneuroimmunology system. So the last thing I'll leave you with in this piece is, for example, autoimmune antibody encephalitis, anti-NMDA encephalitis. So it's only in about the last decade we've actually found the receptor and the autoantibodies to that anti-NMDA encephalitis. So the same as you'll have autoantibodies to any other organ in the body, whether it's the thyroid, whether it's the intrinsic factor in the gut, whatever. Of course, you're going to have autoantibodies to neuroreceptors in the brain. And of course, they're going to present with classical symptoms that we would previously have seen as psychosis. So now if we have a patient presenting with these kind of symptoms, instead of sending them to psychiatric hospital, we admit them under neurology for plasmapheresis, for steroid treatment, etc. So I'd encourage you to be aware that these are not separate issues and they're fully integrated. So where does psychiatry fit in terms of palliative care? We can have a few different types of roles, and this is just to give you some idea that it's not just assessment of psychiatric illness and changes in mental status, diagnosis and advisory treatment, also complex capacity assessments, and also contributing into insight around personality structure, coping strategies, whether they're maladaptive, whether they're adaptive, communication issues. And I've previously done a talk to palliative care entitled How to Care for Patients Who Are Difficult to Care For. So all of those areas, conflict resolution, involvement of family, what we can do is we can kind of give that global overarching biopsychosocial assessment that can then guide the appropriate ways forward from there. And Professor Regina McQuillan and I often work on cases together in terms of what might be helpful in terms of the patient's disorder with our presentation with regard to potential psychiatric or psychological aspects of care. So I'll just briefly refer, and this may be something you're very familiar with already, but just to explain that low mood in a palliative care patient is very unlikely to be due to a de novo depressive illness if the patient has no past history of depression. It's much more likely to be due to, and you'll be well experienced in the delirium and acute confusional states, but quite often we're referred patients, not from palliative care, should I say, but from other physicians with query depression, patients who are physically unwell and have no past psychiatric history. And very commonly, it's actually a hypoactive delirium. So hyperactive delirium, people are confused, it's more obvious, they're pulling out lines, they're paranoid, they're visually hallucinating. Hypoactive delirium can present more quietly, withdrawn, tearful, not eating, not drinking. And unless you're looking for signs of confusion or fluctuations in mental state, it can often be referred as query depression. So much so that you're actually 17 times more likely to die in hospital if you're seen by a liaison psychiatrist than if you're not. And that's hopefully not because we're going around killing all our patients, but rather that we're getting referred patients who are perhaps in their pre-terminal stages of their journey with a hypoactive delirium. And what's really important is to be very clear with the team and with the family that this is not a depressive episode, so that everybody isn't standing back waiting for the patient to recover from that so they can reconnect with the patient. Rather being aware that this is part of the natural slowing down of the patient's brain as part of the rest of their body, and remaining as connected as possible with the patient in this final journey. Also, we don't want to use antidepressants in patients who do not have depression because of the risk of exacerbating delirium because of drop in sodium levels, etc. The other things just to bear in mind is the use of alcohol. 51% of people who use alcohol in Ireland use it harmfully. So if your patient says they use alcohol at all, then it's important to look at their alcohol use, because if you are trying to deal with the challenges of a stressful journey, and if you have a history or a tendency to use alcohol as a way of coping with emotions, that can often be the piece that people can turn to. And it may present as low mood as opposed to, or it may present as non-adherence to treatment pathways rather than a straightforward alcohol. So it's important to check with patients about their alcohol use. Adjustment disorder, you may be familiar with, is probably the commonest de novo psychiatric diagnosis we'll make for patients in these settings, where a patient, and an adjustment disorder is somewhere along that continuum between patients whose response is more interfering and challenging for them than you would expect a usual response to cancer. And obviously that's a very long piece of string in terms of what the person's previous experiences of cancer, how their mother died of the same cancer, breast cancer, whatever, and all those pieces that feed into how a person is going to adapt. But adjustment disorder is between appropriate adjustment response and when it reaches the full level of a depressive episode or an anxiety disorder. So a depressive episode, you have to have at least 2 full weeks of sustained, pervasive, lowered mood or lack of interest associated with a number of other symptoms, not just sleep and appetite disturbance, but also a range of cognitive symptoms that I'll mention when we get onto that. And then finally, the low mood may actually be an appropriate adjustment, but as palliative care, working in palliative care, you have a very good sense of how broad a range that can be, and when a patient's actual levels of distress are significantly impairing their function to an additional degree that requires additional input. Feel free to put up any questions along the way. So I mentioned delirium. So the question is then, of your patients who you see in a cancer or palliative care setting, who is the patient who's most at risk to have a comorbid psychiatric disorder? I would encourage you to think of these just as simple comorbidities. Who's the patient who's got chronic renal failure as well as cancer? Who's the patient who's got diabetes as well as cancer? Who's the patient who's got depression or psychosis as well as cancer? And how do we optimize the treatment of those comorbidities? Because if we don't optimize the treatment, the prognosis for these patients is much poorer than if we do. So that's why it's important in terms of addressing morbidity and mortality and improving the patient's outcomes. So the single most important thing I'd like you to take away from today is a recognition that if a patient has a history of a psychiatric disorder, including substance misuse, but depression or anxiety or panic disorder, whatever, then it's very common that they will have a relapse of their comorbid psychiatric disorder as part of their cancer or their palliative care journey. If they have no history of psychiatric disorder, it's much less likely that they've developed a de novo psychiatric disorder, and you should look much more so for things like delirium. Patients who are socially isolated, and that's been mentioned in our previous presenter in geriatric setting, and that, and we'll be familiar with not just the association between loneliness and poor prognosis in terms of adherence and things like that, but also in terms of actual, again, the psychoneuroimmunological factors in terms of reductions in oxytocin, reductions, impairment of the immune system. So the man whose wife has died is more likely to die himself of stroke or heart attack because of the autonomic hyperarousal, raising blood pressure, raising heart rate, etc. And he's also more likely to die of cancer because of the immune system suppression, in particular colonic cancer, for example. So these patients with psychiatric disorder may present with the language around mood, or they may not. They may present just with a general dissatisfaction with medical care. They may present with non-adherence, not turning up for appointments, etc. So keeping an eye out for those patients. Then there are particular risk factors in itself in terms of the illness and cancer itself, especially the more disfiguring, the more painful cancers. ENT cancers classically being associated with alcohol and nicotine dependence, etc. More likely to be associated with a comorbid psychiatric disorder. Sorry for the sound effects there. And then the treatment itself, and in particular treatments such as bone marrow transplant, which are very, very challenging treatments. Requiring six weeks of sustained isolation, etc. Equally, you'll be familiar with the side effects of medications, a whole range of chemotherapeutic medications, but I'd ask you to pay particular attention to steroids. Steroids is a very, very toxic medication. Classically, what we see is alerting effects from steroids, energizing effects, alerting, affecting sleep, often can give a patient a useful boost in energy, but actually can be associated with agitation and can be associated with anxiety and can be associated with lowered mood. And what gets called steroid psychosis, I tend to think of it as more as a delirium related effect of steroids. So being mindful that may be one of the presentations. I always tend to say to the treating team, I ask them in terms of proposed steroid treatment, if there are concerns about a patient's mental state, for example, if they have a history of bipolar disorder and that, what is the impact of the steroids likely to be in terms of their prognosis? If it's not going to make a huge difference, then minimizing and using a steroid sparing regime is important. But if it is going to make a significant difference in prognosis, then give them the full treatment, and we will use our psychotropic medications to try and manage any associated mood change or psychosis associated with that. So depression in palliative care, as you know, there are lots of reports of lots of different prevalence rates, but probably we're talking something about up to 20%. For patients particularly who have a sense of loss of meaning, lower spiritual well-being, and then certain CNS lesions, paraneoplastic syndromes, etc. And the paraneoplastic syndromes undoubtedly, from my point of view, relate to the autoantibody effects, and just that we haven't actually found which are the particular autoantibodies as yet. And then certain treatments, as you know, whole brain radiation, steroids, as I've mentioned, interferon has a significant mood-related effect, etc., and a number of chemotherapeutic agents. So the piece in terms of determining whether somebody's terminally ill and could this be depression, you're really distilling out two main things. First of all, has the patient any past history of depression or anxiety? Now, sometimes you need to kind of go not just into have you been diagnosed with anxiety, but have you always been a worrier? Have you always been somebody who's worried about things, even if they haven't presented to their GP or secondary care? So you have that piece in terms of the likelihood or not. The second piece then is, because of the prevalence of biological symptoms and the overlap between biological symptoms of depression and the overlap of biological symptoms of a whole range of obviously cancer-related or palliative and terminal illness related symptoms, you're going to focus more on the psychological or the cognitive rather than the sleep or the appetite symptoms. Now, interestingly, fatigue it's important to be aware that in fact fatigue can be associated with the, for want of a better word, the biological component or the psychological cognitive component. And St. James's have done a really nice booklet now on the management of fatigue for patients and cancer patients, the role of deconditioning, etc. And it's important to consider that. But what you're really distilling out is the psychological or cognitive symptoms, and you're looking at things like hopelessness and suicidal ideation. And in looking at that, even mild suicidal ideation, you should start to look quite in depth for significant depression. So what do we use? We use a combination of lifestyle management plus or minus medication. The same as we use for diabetes, the same as we use for cancer, for anything else is the same as we use for treatment of mental disorder. No one says you're getting addicted to your insulin if you're diabetic, and yet this is the language we use when we're treating mental disorders for no good reason. What we're talking about, the organ being the brain, and we're talking about the neurochemical being serotonin, the management, lifestyle management, plus or minus medication. So SSRIs is our go-to if the patient has a prognosis over a few months. They use low-dose stimulants in the States, but there is not a strong enough evidence base from our point of view to use it over here. And then you'll be very familiar with those patients who've got a much shorter time frame in terms of the sedatives or infusions that you'll use. Starting low before you increase the dose, and then a range of psychotherapeutic interventions. I just guide you to these online programs now. During COVID has been one of the benefits of COVID in terms of, for all patients living with chronic conditions, the livingwell.ie is a free online 6-week program, very, very good program that helps people to work on symptom management, fatigue, emotions, physical activity, pain management, medication management, planning for the future. So I highly recommend that for any patient with any chronic condition. The stress control is a really, really good program also that outlines for patients in a similar 6-session how to manage stress, the relationship with your body and your thoughts and actions. So highly recommend these 2 programs. Obviously, there's a range of things associated with survivorship programs, etc., that you'll be familiar with through the cancer centers, etc. There's a whole range of mindfulness-based apps and things like that. And for example, we have in Beaumont, which can be accessed by anyone, the Mindfulness and Relaxation Center that takes people through relaxation breathing, visualization exercises, body scans, etc. This is just to refer to then the community cancer support centers and how this is going to be developed further going forward. So the ARC centers, the Gary Kelly centers, etc., will have not just the services that are currently in them, but as part of the National Clinical Cancer Program psycho-oncology service in terms of community supports, there will be psychologists and social care practitioners embedded in the cancer support centers, and a hub and spoke model that I'll refer to shortly in terms of the national cancer centers. Medications, SSRIs, you'll be familiar, and the previous speakers spoke about the use of mirtazapine, can be very nice for older patients who've got problems with lack of sleep, nausea and anorexia. Venlafaxine, our low-dose tricyclics. Duloxetine, in my opinion, has been overplayed, but I'm a skeptic of new pharmaceutical-based information. So for neuropathic pain, and then the use of venlafaxine and SSRIs for the hot flashes as well. So you'll be familiar with the tamoxifen piece around the 2D6 inhibitors and the importance of not using paroxetine, fluoxetine, duloxetine, as it might decrease the efficacy of tamoxifen. So venlafaxine can be helpful both for the, if you need it for the comorbid mood disturbance, whether it's anxiety or low mood, and also can help with the hot flashes. Citalopram, escitalopram, also useful for those patients. I'm going to just skip through this in terms of suicidal ideation. Really, you're looking at all the regular risk factors, males, older patients, history of self-harm, psychiatric illness, along with uncontrolled pain, advanced stages of the disease, hopelessness, etc. And I'll just briefly allude to an area that palliative care are very invested in, as the rest of us in medicine are, in terms of the physician-assisted suicide, euthanasia, dying with dignity bill. And we know that depression plays a role in requests for hastened death, and the depression and hopelessness are the strongest predictors of desire for hastened death in terminally ill patients. And Fergal Toomey has been doing fantastic work in coordinating response both through the palliative care community, through the RCPI. We've been progressing with that through the College of Psychiatrists, the geriatricians, through Des O'Neill, etc. So the main motivations for physician-assisted death, we know, are the fear of loss of autonomy and dignity, decreased quality of life, and mental distress. So what I'd like to now, just for the last 5 minutes, before we have 5 minutes for questions, is just to actually address the theme of the conference, which is dynamic changes in oncology and the impact on palliative care. And I'm going to introduce the very exciting concept of national developments in oncology. And so what we're talking about is the National Cancer Strategy 2017 to 2026, where in recommendation 31, designated cancer centres will have sufficient complement of specialist palliative care professionals, including psycho-oncologists. The next piece, then, we have the Adult Palliative Care Services Model of Care produced in 2019, which makes some reference to this area of psycho-oncology. And finally, then, we have launched in September 2020 under the leadership of Helen Greeley, the model of care for psycho-oncology through the National Clinical Programme. So for the first time, the National Cancer Programme is actually putting in designated funding for psycho-oncology services. So in the model of care, palliative care services, it talks about the design of this integrating with the cancer strategy model for psycho-oncology and the design of psychiatry services more broadly, the use of a stepped care approach, and how we link in how our programs integrate. It does refer to additional resources not covered by the National Cancer Programme Psycho-Oncology for those patients whose morbidity isn't met by the psycho-oncology, for example, patients in palliative care, inpatient care, or who aren't under the care of an oncology service, and also for that other group of patients who are receiving specialist palliative care without a cancer diagnosis. So, for example, patients with end-stage anorexia nervosa, and there has been some collaboration with the National Clinical Programme for eating disorders and for palliative care. And so just to briefly refer to what it actually says in the model of care for psycho-oncology, the aim is to support families in their psychological well-being, to guide the planning and building of capacity in the MDT teams and the community cancer support, so both in the acute hospital and in the community cancer support, increasing awareness of the supports and enabling patients to have access to those interventions and support whatever way will be most useful to them. This is the model, the stepped model of care. And just to give you an idea in terms of the transient distress, education, information, persistent mild distress, cancer teams, the clinical nurse specialists on the cancer teams, palliative care teams, community cancer support centres, group psychoeducation, etc. And there's a lead out e-learning program now that will be coming for all patients as part of their cancer journey. Then patients who have more significant distress involving social work on the team and or the mental health services for those patients where they're already integrated within those teams. And then specifically for patients whose levels of distress are severe and require psychology and or psychiatry, or organic state psychosis, suicidality, which come directly to psychiatry for the first point of assessments. So diagnostically in terms of the contribution of delirium, brain tumor impact, etc. And so there's a fluidity up and down the stepped ladder in terms of how we work together. So what will happen is in each of the cancer centres, there'll be a psycho-oncology MDT comprised of psychologists, senior and specialist principals, a consultant psychiatrist, clinical nurse specialist, and senior social worker. So in each of the 8 cancer centres and in the paediatric cancer centre. The proposal is to screen for distress of patients at 2 minimum points in their cancer journey, and that the psycho-oncology MDT links in with oncology and hematology, survivorship programs, nursing education programs, etc. Scoping questions for assessing distress, how are you feeling today, how are you coping, and patients being aware that this is part of their cancer journey, and the suggestions of time of key transition points. It means the time of perhaps your 2, whether at the time of diagnosis, at the time of transition to survivorship, or at end of life, to the key points for assessment of distress. So this is the proposed patient pathways that all patients in their cancer journey will get an introductory information leaflet and a baseline psychosocial evaluation to clarify then where they are along those levels and what the appropriate services will be and how that will be monitored. So my second last slide is, this is just looking at an overview of the patient pathway assessment of needs, the complexity of the assessment of needs, the care plan and who should be involved and where that relates to in terms of bereavement as a kind of a general outline, but then the specifics with regard to transient, moderate, severe distress and where that fits in terms of linkage in through the oncology team with the psycho-oncology services and the availability of supports in those areas. So what's happened now, we've had our first year of funding of the MDTs. In Beaumont, we've been fortunate to get funding for a full-time consultant psychiatrist and a full-time clinical nurse specialist in psycho-oncology to set up the nidus of a team. And each of the cancer areas have a number, but the aim is for each cancer service over the coming years to have access to the full through release of further funding. So that's where I'll end. Hopefully we have time for a few questions from there. So I'll pass back to you, Michael, there now.